conclusion of this high-level data is that circumcision should be included as the prevention measure guidelines, and it is warranted. Who should be screened? The CDC tells us, according to their guidelines, people who should be screened routinely are those who are 13 to 64 years of age, those who are initiating treatment for TB, those who are at high risk, obviously, with high-risk sexual behaviors, those seeking treatment for STDs, at each visit for every new complaint, okay? And obviously pregnant women. When comparing screening guidelines from different associations like the AAFP, ACP, CDC, and the USPSTF, the AAFP says pregnant women should be screened and those at high risk. The ACP says we should just adopt general routine screening with not being specific about it. The CDC obviously says those routinely should be screened 13 to 64 years of age, pregnant women, those seeking treatment for initiating treatment for TB, seeking treatment for STDs at each new visit for a new complaint, and pregnant women. The USPSTF said in the past that those who are pregnant and at high risk should be routinely screened, but was neither for or against routine screening in the general population. However, they changed their policy in 2013, this year, April, and that they broadened their guidelines to routinely screen those who are 15 to 65 years of age. And similar to the CDC, which was saying 13 to 64, they're saying 15 to 65 years of age. And anyone above or below that bracket is of an increased risk, and obviously pregnant women as well. So those who are infected, what does the IDSA say that you should do at each visit for them? Well, at each visit they should be screened for high-risk behaviors, and at each visit they should be asked about symptoms for STDs. What are high-risk sexual behaviors? Well, based upon the evidence and the data that we've seen and from the CDC, it is obviously things like male-to-male sexual contact, intravenous drug use, high-risk heterosexual behavior with multiple sexual partners, lack of condom use. Okay, so what can we do, what interventions can we do to kind of prevent these high-risk behaviors? Well, there's something called VCT, and it's basically, this is a definition from the UNAIDS Council. It's essentially just voluntary counseling and testing centers, whether mobile or clinic-based, and essentially where someone can go in and get voluntarily get tested, and then get pre-test and post-test counseling. So, I mean, they have these set up in certain geographic locations, especially in some of the developing countries. Does it do anything? Does it have any, effect? Well, it showed in over 17 studies, 8 of which were meta-analyzed in 2012 in a Cochrane review, that it actually did reduce high-risk behaviors in developing countries, and it reduced the number of sexual partners of participants, and it increased condom use amongst those who were infected. And this actually is something maybe we should look at in areas where there is increased incidence, and see if this is something we should institute more. Moving on to diagnosis and initial management of acute HIV infection, which I like to call the acute retroviral syndrome. So, within 90 days of being infected, 50 to 90% of persons develop the acute retroviral syndrome, characterized by low-grade fever, rash, diarrhea, nausea, vomiting, pharyngitis, headache, possibly septic meningitis. It may show up 1 to 4 weeks after exposure. So, they present to your office in a primary care setting, just like it has for me in the past. And I was very highly suspicious. Why? Because they had a lot of these generalized, non-specific constitutional symptoms. This was a person who was discharged from the hospital after a 2-day hospital stay for a right upper lobe pneumonia, and then was not feeling any better 2 days later. But she had been repeatedly tested for HIV in the past, but the last testing was 2007, and we were concerned. She had fever, fatigue, rash, lymphadenopathy, headache, a lot of non-specific things. So what would you do? If you do some lab work on these people, typically you do some baseline laboratory testing first. They might have a low platelet count, they might have a low white count, their LFTs may be elevated. you know, it may be very hard to differentiate between mono. So, talking about the diagnostic value of signs and symptoms in acute HIV infection, basically there are some that are more sensitive and there are some that are more moderately specific. What does that mean? Well, if we have ones that are more sensitive, then it's saying that if they're presenting to you in your office and they don't have these symptoms, you could say with a moderate level of assurance that they might probably do not have the acute HIV syndrome, especially if they're not presenting with fever or fatigue and malaise. It's not a high level of assurance, but I would call it moderate. And then if they are presenting with these type of symptoms that are moderately specific or moderately specific, then you could say that if they are presenting with these symptoms, you probably better have a low level of threshold for suspicion, especially if you're having mucocutaneous ulcers, rash, anorexia, weight loss, and GI distress. So, what could the differential be in this patient population? I mean, they could have mono, they could have the flu, they could have just a simple strep throat, they could have a GI bug, or they could just have a simple viral upper respiratory tract infection. If they do have a rash, this is what the exanthem might typically look like in an acute retroviral syndrome, this kind of eruption, generalized eruption. How do you differentiate it from mono? Well, the acute HIV is going to be more acute onset. Typically, there's little to no tonsillar hypertrophy. They generally don't have tonsillar exudates. Mucocutaneous ulcers are more common, as is rash and diarrhea. And they actually may present with an opportunistic infection and actually may have AIDS at the time of presentation. However, mono would not have these things and would likely have tonsillar hypertrophy and exudates and no mucocutaneous ulcerations. So looking at this graph, regardless of initial symptoms, most patients subsequently enter a prolonged asymptomatic phase characterized by reduced viral load and some viral steady state or set point. Okay. Unpredictably, viral replication may eventually exceed immune response, leading to persistently elevated viremia and associated drop in CD4 cell counts. As the CD4 cell count drops, the patient becomes increasingly susceptible to opportunistic infections, including AIDS-defining illnesses, and this is what's going to kill them. Okay, so in the acute infection, the acute HIV syndrome, if you were to test them, you know, their CD4 count is going to be low, and their HIV viral load will be typically high, typically above 1,000. But that would then turn around as they get treatment or on their own, and once they're started on treatment, they may actually fail treatment, and then there is a sustained viremia and failure to sustain CD4 levels, and that's how the disease progresses. Here's a question. A 27-year-old gay man has a negative HIV serology but continues to practice high-risk behaviors. He requests assurances that he does not have HIV infection. The most sensitive blood test to provide this assurance is correct, routine serologic testing. Okay. I just wanted to go back to this one quickly. You can see that it is 0 to 3 weeks or is up to 28 days before you may actually be able to detect the disease by standard testing. So again, we'll talk about that window period. So what does the IDSA say is the standard testing? They say that it is the rapid or conventional ELISA, followed by a confirmatory Western blot or an indirect immunofluorescence assay. These are the tests, the rapid and standard ELISA for screening, Western blot for confirmatory. You'll see that in the window period, we talk about things like the HIV RNA PCR or P24 antigen assay. The CDC, what did they say about it? Well, in 2006, their standard screening and diagnostic testing guidelines say the same thing as the IDSA. Standard screening consists of the ELISA for screening and followed by confirmatory Western blot. Those that increase low suspicion should probably have a repeat confirmatory test in 3 months. Those who are of a higher risk should probably have repeat testing 1 month, 2 months, and 6 months later, and possibly even 12 months later. And this is the type of counseling, pre-test counseling, as well as post-test counseling primary care providers should be providing when they do standard STD screening. The rapid ELISA has a quick turnaround time, can be done confidentially in your own home. It is low cost, but not as sensitive as the standard ELISA. There are different manufacturing products out there, like the OraQuick, the Unigold. Patient came to me saying I had 2 OraQuicks done at home and there were negatives, but I'm still very suspicious my partner had high-risk behaviors. What am I to do? Do I just go directly to the confirmatory Western blot? Well, according to the guidelines, I went to the standard ELISA, and because it is more sensitive. And so the standard ELISA is more sensitive, but even if that's negative, what's the most common cause? And it could be that acute HIV infection where we talk about that window period, that 0 to 3 week or 25 to 28 day period where the viremia is not high enough to give an antibody-antigen response. So when we talk about that window period, you see over here, that's where the ELISA is detectable only from that point on, the 28-day period or whatever. But when you see what can you test before that, and that is the P24 antigen or the viral RNA PCR. Of the two, which one should you do? Well, they say that the viral PCR RNA is the better one to do because the P24 antigen, as your immune antigen complexes increase in the body with the elevated viremia, the P24 antigenemia decreases and you are not able to have sustained levels. So the RNA-PCR assay is not as sensitive and it should not be a standard tool for initial screening or diagnostic testing. However, it is useful in certain situations like the window period or if there's an indeterminate Western blot or to monitor response to treatment. So those who are having the acute HIV infection, you've diagnosed it, you're there to treat them, and how should you counsel them? What should you be doing in the initial evaluation and for baseline laboratory testing? Obviously, the IDSA says you should do a comprehensive history and physical. They should also be screened for depression and domestic violence, as these issues occur in increased prevalence in this particular patient population. What baseline testing should you be doing? I mean, the primary care provider should not just reflexively be referring them to an infectious disease specialist or HIV specialist. You can, and early referral is recommended, but you could kind of get them prepped and packaged to go and get some of the testing done. And they do recommend you get a baseline CBC, CNP, obviously a CD4 count, HIV viral load. Because of virus mutation and leading to treatment resistance, they recommend the HIV genotype testing be done. You get STD testing done for them for syphilis, hepatitis, chlamydia, GC. A PAP should be done in women, and in men in high risk, anal PAP can be considered. And also for opportunistic infection screening, toxoplasmosis serology is recommended as well. So the AAFP key recommendations, to summarize what you should do, essentially state the same things. I don't necessarily have to go over all of them again, but interestingly, it says 2 sets of CD4 lymphocyte counts and HIV viral load levels should be checked within 4 to 6 weeks to monitor level of immune suppression and viremia. Now talking about treatment, I think we're good with time, so we can go ahead. We talk about different drugs that intervene at different stages of the life cycle of the retrovirus. So we have the typical classic medications like the reverse transcriptase inhibitors and the protease inhibitors. And then you have some of the newer ones like the integrase inhibitors, co-receptor inhibitors, fusion inhibitors. We're not going to really focus on those newer ones because that is beyond the scope of this presentation. But that is part of the reason why I wanted to address this, because for the general medical population, we should have an idea about these drugs, and we don't, and I don't. And we should know kind of what are they, and how are they used and their adverse side effect profile. So the reverse transcriptase inhibitors, there's 3 types of them. There's going to be the there's going to be the nucleoside, and bear with me, these are hard to pronounce. nucleoside reverse transcriptase inhibitors, the non-nucleoside reverse transcriptase inhibitors, and there's actually a third type not listed here, the nucleotide reverse transcriptase inhibitors. And I like to make that very clear so that we can actually just remember what the 3-drug regimen actually is. Okay, so we have the NRTs, the NNRTs, and then that third kind, I like to call it the NTRT. Nucleoside, non-nucleoside, and nucleotide. And then we have, of course, the protease inhibitors. Okay, we'll concentrate on those. When we're talking about a typical 3-drug antiretroviral regimen, it will typically be 2 of the NRTs, like zidovudine, lamivudine, abacavir, or it'll be 2 NRTs plus either an NNRT or a PI. Okay? So that is the typical 3-drug regimen, and it may be boosted with another PI like rotenavir. And the more advanced drugs are typically reserved for patients who are treatment resistant or for salvage therapy. So if you're using 2 NRTs and either a NNRT or a PI, well, the patient may ask you, well, which one should I use? Which one's better? Is it the NNRT or the PI? Well, there were 12 randomized controlled trials done, and 2006 they were meta-analyzed and showed that they had both similar efficacies, the NNRT and the PIs. It really doesn't matter, you can use either one. They're both equally efficacious, and there was another 2007 randomized controlled trial that said that they showed similar findings. Well, what about a 2-drug regimen versus a 3 to 4-drug regimen? Part of the problem with HIV is compliance and a high pill burden with having to take so many medications. So, you know, would it be better to use a lower pill burden combination, like a lower drug regimen? Well, actually, there was 4 randomized controlled trials that were reviewed in a systematic review in 2003, which showed, although it reduced the pill burden, the lower drug regimen had a problem suppressing the virus as well. And the higher drug regimen lowered the amount of viremia in the blood, improved immune system function, and slowed the progression of HIV. What if you cannot tolerate an NNRT or a PI? Can you use 3 NRTs as opposed to 2 NRTs and something else? Well, there was 4 randomized controlled trials that were meta-analyzed this year, which showed that to assess the efficacy and safety and tolerability, such as this specific drug regimen, abacavir, lamivudine, and zidovudine, and it actually showed that this remains a viable option and can be used, especially for patients who are intolerable to a PI, like those who, for example, have pre-existing hyperlipidemia and cannot tolerate something like ritonavir. What about the NRT versus an NTRT, a nucleotide versus a nucleoside? Well, can you, switch one with another? Can you use one in the case of the other? Well, it showed that a nucleotide reverse transcriptase inhibitor like tenofovir actually was just as efficacious as zidovudine and NRT, but actually was superior in terms of its immunologic response, adherence, and in terms of more frequent emergence of resistance. However, head-to-head trials are needed. And lastly, I know this is kind of redundant or confusing, but what about the NNRTs? You use typically 2 NRTs, and if you are going to use an NNRT, well, there's not many options. So typically, if they may ask, which one should I use? Well, they compared 2 of the most commonly used ones, efavirenz versus nevirapine, and it did show that they were both equivalent in their efficacy and initial treatment. However, efavirenz had a slightly less side effects and more likely to prevent death, I guess, because of that reason. So when to start treatment, there is some controversy as to when. Do you do it earlier? Do you do it later? How long do you wait? How far down do you wait for the CD4 count to drop? Well, there was 2 randomized controlled trials done in 2010. They were meta-analyzed to see, should you wait till they drop till 350, or should you wait till they drop to about 250 or 200, the CD4 count. And this clearly showed that initiating treatment earlier with antiretroviral therapy at a CD4 count less than 350 did reduce mortality rates. So from the IDSA and AFP, they do recommend that treatment is generally initiated when